Now, when I was invited to give this talk, I was not given a lot of guidance as to what to talk about. And I decided that what I would like to do with the next 15-20 minutes is to give you my perspective, evidence-based, I hope, of what I believe the future of treated HIV is going to look like. And so I'm going to look to the future and try to identify what I believe are going to be some problems. Some of them we can address up front. As it pertains to long-term treated patients. What does a patient look like after they've been on combination antiretroviral therapy, for decades? But let me just sort of go back in the past and just outline where we've been. I think many of us in this room have contributed over the past 25 years to what was truly a spectacular outcome, right? The development of antiretroviral drugs. The focus of industry, clinicians, community, academics, government, for the past couple of decades has been to develop drugs which are designed to block HIV from replicating. And as a consequence, the immune system gets better, and as a consequence, people don't get AIDS and they have prolonged life. And we've been successful. With a tremendous amount of basic science identifying the targets, industry was able to identify drug candidates, and the clinicians and patients and community were able to basically move very quickly forward and identify, over 20, 25 potent, safe antiretroviral drugs, developed multiple viable regimens, many of them now once a day. And it is pretty clear that for the patient who has drug-susceptible virus, who is motivated to take drugs, and who critically has lifelong access to therapy, AIDS is no longer a problem. But before going into what I believe might be the problem, I think it's just important to emphasize that from my perspective, the key unmet need, of course, is not necessarily dealing with the complications of long-term treatment, which exist, but getting more people on these drugs, right? Because these drugs are obviously life-saving and have had a tremendous impact on multiple aspects of the epidemic, including health and transmission. There are certainly millions of people out there who are in need of these therapy. The goal should now be to, of course, go out and find these individuals, get them on therapy. And of course, I think as of today, with the new WHO guidelines, the number of people who should be on therapy, I'm sure has increased dramatically. The number of people who should be on therapy but aren't has gone up substantially. I'm not going to talk about the untreated patients and the need to get them in, but again, rather talk about what happens when you get them in, get them on therapy, wait a few years, what happens next. And what happens then is that HIV becomes essentially a chronic disease, very similar to other chronic diseases that general internal medicine, primary care doctors have to deal with. And the HIV is a chronic disease, from my perspective, is going to be characterized by persistent low-level immune activation and immune dysfunction, subtle side effects that are hard to quantify, but are likely to prove cumulative over years and decades, excess comorbidity, other non-AIDS conditions, heart disease and so forth, all of which can impact on healthy aging, and I believe in certain areas of the world, particularly those that really have limited resources, a shift to chronic disease management might in fact overburden, stretched and poorly resourced healthcare systems. And so this is sort of where I think the big issues are going to be in the future among those we get into therapy and treat. So let me talk first about the issue of inflammation. This is an issue that's been a tremendous amount of discussion going back decades on now. There's a fair amount of really high quality research, some symposiums, some plenaries here about this issue. Here's my perspective. And a lot of what I'm about to talk to comes out of my colleagues in the Insight Network that have really driven the agenda in this regard. But probably one finding among many, but I think this is probably the best study by this Insight group. They identified if you took a group of long-term treated people and you measure inflammation, with various biomarkers. In this study, they looked at interleukin-6 and D-dimers and so forth. And you look at a group of people who don't have HIV, but are well matched, not perfectly matched, but as best matched as you can, similar age and so forth. People with treated HIV, otherwise apparently doing well, have increased levels of inflammation. Multiple inflammatory markers. Now, the increase, of course, is not dramatic. It's not a log. It's 50 to 100%. Higher than you might expect. The key thing is, and this is the most remarkable thing from my perspective with regard to HIV that makes it a little bit different than other chronic diseases, is that these subtle increases in the inflammatory markers, IL-6 and D-dimers being the best characterized, has a dramatic effect on the future. So if you have subtle increases in IL-6 in 2000, in this work from the Insight Network, that increase will predict excess risk of morbidity and mortality for the next several years. Something not really ever seen in other medical conditions. So inflammation is high. It has a dramatic effect on predicting the future. And the effect is actually quite durable. And this has been seen in multiple studies now, and there's multiple different biomarkers, but again, I believe right now IL-6 and D-dimers are the ones that are best qualified, best characterized. But why is this a problem? So if you venture out of the HIV world, and particularly look at what's happening in the world of autoimmunity, rheumatoid diseases, cardiovascular diseases, and particularly geriatrics, very similar observations are made. Chronic inflammation appears to be at least predictive and likely causal of some of the excess morbidity that's seen in each of these patient populations. In HIV, elevated levels of interleukin-6 D-dimers, CRP, monocyte activation, and so forth, soluble CD14 has been associated excess mortality, cardiovascular disease, certain cancers, DVT, metabolic complications, and so forth. In study after study, it's very consistent. And I believe that has led, that single problem, along with the issues of treatment toxicity and so forth, have led to the increased risk of these various different conditions. Now, what are the data? That people with HIV are getting more sick from non-AIDS conditions like cardiovascular disease compared to people without HIV. There have been dozens and dozens of studies, some from our group, not nearly definitive, with lots of methodologic problems that are inherent when you ask what is happening to a group of people with HIV versus a group without HIV, because they're fundamentally different people with lots of different issues. Amy Justice and Matt Freeberg, I think, have done probably what might end up being the gold standard study to try to really tease down what is the independent effect of HIV on these excess risks. And they did this in the Veterans Administration's medical system in the United States, which captures a lot of covariate data and follows HIV positive and HIV negative people in the same clinic. And they went back and looked at some 80,000 individuals within this system and asked the question, if you control for everything known to be associated with cardiovascular disease, hypertension, substance abuse, so forth, and age and everything else, how much more likely is an HIV-infected person to get heart disease than a person without HIV? And the effect is actually shown here at different age groups, between 30 to 40, 40 to 49, 50 to 59, and so forth. And as you can see, in general, there's about a 1.5-fold increase in developing heart disease for those who have HIV versus not, after controlling for everything else. And that's a real effect. In fact, that effect size is comparable in this study to the effect of the classic predictors, including, remarkably, diabetes. The effect of diabetes, which you often think is a very powerful driver of cardiovascular disease, in this same study had an effect size around 1.7 or so. But hypertension, and so they're all in the same ballpark. So there is, I think, consensus building that HIV is indeed a major risk factor for heart disease. Now, most people in their 40s or 50s don't have heart disease, don't have MIs. So doubling that risk is not actually going to cause a major increase in the amount of disease that we're seeing today. The average age in a lot of our clinics in San Francisco is in their 40s or 50s, so we're not really seeing a lot of it. But as people get older, the absolute number of events is expected to rise. And this is true, same effect size is true, not just for heart disease, but for bone disease, neurologic disease, kidney disease, cancer, liver disease, not well studied, but always come up with these same 1.5 effect sizes in the study. Peter Rice and his colleagues in Amsterdam did a very elegant study where they actually asked the question among people, I think over the age of 45, if you count up the number of diseases that people with HIV have, and when I say diseases, I mean the typical non-AIDS diseases we're talking about, the ones outlined here. Anemia and hypertension, diabetes, and so forth. And compare it to a similar group of HIV uninfected people in the same clinic. They found that about half of patients in their 50s, which is not that old, have at least 2 comorbidities. And that this number, which is a high number for men in their 50s, men and women in their 50s, that number is comparable to what you see in HIV uninfected people about 10 or 15 years later. When people have done these studies, when they've asked, what does an HIV-infected person look like compared to one without HIV, you often get that same number. It looks like it adds a decade in terms of some of these age-associated complications. Now, why is this important? Again, if you're in your 40s or 50s, it's not that big of a deal because the absolute number of risk is not that great. This is where I'm going off and speculate a bit. So I've spent a fair amount of time, and I think that the field needs to do this. I think we need to bring in experts from other disciplines, particularly geriatrics. If you ask geriatricians, what is the real concern about early onset of inflammation, comorbidity, and so forth, they will say that this can lead to cumulative harm, which will only show up 2 or 3 decades later. This is a well-accepted conceptual model of geriatric aging that the comorbid conditions results in a loss of redundancy, inability to compensate, and early onset of what we call aging, frailty, and so forth. And I think this is very important because I think there's something we can be doing about this now. But if you look at what are the known risk factors for aging, it's polypharmacy, it's social isolation, it's multiple comorbid conditions, it's chronic inflammation. It is very similar to the picture of the patient that I think is on long-term therapy. So it does suggest that many of our patients are doing well now, but in a few decades, when they're older, when we really want them to maintain their health, some of this stuff may catch up with them. And that's an important point because I think we can do something about it. Is there data for this? Yeah, if you look cross-sectionally in things like MAX and other cohorts, you'll see evidence that frailty is more common in people with HIV than not. It's associated with higher levels of T-cell activation, and so forth. The other issue, which I think is related to this, that I don't think has been that well studied, and I had a hard time finding data along these lines, is that this problem, which has been primarily studied in Europe, the United States, and so forth, appears to be playing out globally. And here are a couple studies that looked at what's happening in sub-Saharan Africa, where the population tends to be much younger than certainly in San Francisco. But if you ask the same question, are there excess comorbidities compared to HIV negatives? There are. If you ask the question, are the number of comorbidities of Africans higher? Things like obesity and hypertension and diabetes, are they higher in Africans with HIV compared to Americans with HIV? They are. And I asked the question, is the population aging? They are. So the same situation that's happening in the cohorts in the United States that I just outlined is likely happening on a global level. And if so, it would argue that as HIV becomes a chronic disease, which is not a bad thing, right? I mean, people are living longer. Some of this stuff may actually become more and more important. And I do think that there is others who have more expertise in this area are aware of this and are beginning to wonder we need to shift our resources to account for the type of care such individuals will need. So just, I actually spend a fair amount of time talking with my patients about this stuff, and I try not to be too pessimistic. And I say, there's things we can do. There is a tremendous, we know a lot about the mechanisms for why inflammation occurs. We, all of which have targets. We know why inflammation might cause disease. They have targets. There are multiple drugs that are now moved into the pipeline to try to reverse this process. So there's reason for excitement that at least we're doing something about it. There is this increasing evidence base that if you really want to reduce or prevent that long-term cumulative residual inflammation over decades and decades on heart, you might be able to do that by getting people on therapy earlier versus late. And this is something that's going to be studied in the START study, which is still ongoing, and hopefully will be informative in this regard. But what do I do in the clinic? So when I get, so this is again informed by my geriatricians. They say, listen, if you want your patients to be playing tennis when they're in their 70s or soccer or whatever, you need to start in their 40s and 50s, and you need to basically do what the only things that are known to affect healthy aging. And this is what I spend all my time in the clinic doing. All my patients are on treatment, they take their drugs, plus or minus, but they're doing okay. And I spend all my time, talking about exercise and aggressive management of lipids, hypertension, Mediterranean diet, and so forth. And so that is actually, in my mind, the future of long-term, stable, treated HIV infection among those who have access to therapy and who take their drugs. Let me just end and just pose the question, and this is, I'm not going to try to be overly optimistic, I tend to be so, and just throw out there that there are a number of problems with heart, right? It's a spectacular success, there's no question about it. We got to get more people on therapy, that's the priority. But once there's on therapy, there's some issues, right? There's toxicity, there's cost, there's inflammation, there's comorbidities related somewhat to the inflammation, related to the drug toxicities, and there's these overburdened healthcare systems. Could a cure, a true cure, if we were to cure HIV-infected people, could most of this get better? And that's a testable hypothesis once we come up with a cure. And there is tremendous interest now, globally, lots of excitement all over the world in developing cures. Now, there is substantial barriers to curing HIV infection. Some of these may be insurmountable. But Francois and I and Sharon Lewin just chaired a 2-day meeting. It was very rigorous. It was very exciting. There was a tremendous amount of data. It was one of the best meetings I've been to ever. Lots of cutting-edge stuff. You'll hear about it throughout the week. That make me optimistic that we are now truly, as a field, working together, understanding the barriers to a cure, identifying targets that go after the cure, and doing the first inpatient studies. And now coming up with a list of anecdotes, to a certain degree, that suggest a cure is possible. There's the so-called Berlin patient that everyone's aware of. There's the baby cure, which we heard updates about over the last couple of days, which I think represents a clear-cut cure. There's the well-known Visconti cohort that Francois was talking about. These are 14 individuals who were on therapy, very early stop therapy, seem to be cured. You will hear some very exciting data on Wednesday in a late breaker by Tim Hendrick and Dan Kriskus in Boston about the potential use of allogeneic stem cell transplants for cure in patients who need a transplant, of course. This is without CCR5 depleted cells. I'm actually quite encouraged by some of the therapeutic vaccines, particularly the dendritic cell vaccines, which may actually be curative to a certain degree, and we heard some data the last couple of days about that as well. And finally, and most importantly, most of that stuff is expensive, toxic, not easy to scale, but there is a number of small molecules that are now being developed that I think are showing that we can intervene and do what we did with antiviral therapy way back in the day, which is upset the steady state, change the equation, begin to affect the reservoir in a way that could lead to a cure. And another very compelling data set was presented here that I actually think is some of the most promising data in this regard, that you can do this with a pill, will be presented by our colleagues in Denmark in a late breaker later this week. I encourage you to go to those presentations because I think you'll share my excitement that there's a potential for a cure. And if you think about it, where are we, right? We're basically now learning the biology, identifying mechanisms, identifying targets, doing first-in-patient studies, identifying drugs that work but are not going to cure on their own. So we're essentially where we were in the 80s with antiretroviral drugs, and we know what happened after that. And I think this is all going to happen in large part. Francois and the International AIDS Society had a vision to put together an international group of people to collaborate and come up with a series of guidelines. They asked me to chair it along with Francois, but by the time I got to the group, most of the work had been done. But that's fine. I took some credit for it. And this, I think, has really energized lots of people to get together. And there are now multiple groups that are coming together to collaborate to work on a cure. So to conclude, here's where I think we are going, right? I think in the future, yeah, we need better drugs, and we have to figure out which drugs should be first and second in Africa and elsewhere. But for the most part, treatment works great. We know how to treat people. What we do need to now know, we've got to pour more money and more emphasis into test and treat and getting people in care on this therapy. And then once we're on therapy, we've got to figure out what's going on with the immune system, with the chronic inflammation, prevent that, reverse that. We've got to learn how to aggressively treat people. Do they need to be on aspirin? Do they have to be on Lipitor? Do they have to be on statins? What's their blood pressure? What should be their cholesterol? And I think we should all be getting together with our patients in their 40s and 50s and talk to them about how to make sure they're healthy in their 80s and 90s. Build better systems and make sure patients are as healthy as possible, so they're around for the cure. A cure could take 2 decades. Most of my patients are in their 50s, so they need to get it together if they're going to be around the benefit. I'd like to thank the individuals here on this figure who sort of are my colleagues that I work most closely with, who stimulate some discussion. Thank you very much.